All right, let's go ahead and start the second part of creating a culture of care. And in that, we're going to delve a little bit more into the different types of nursing care delivery systems and some of the things that actually happen within the hospital. So this is, again, probably something you've kind of heard a little bit about but never really thought a whole lot about in any one shape or form. But your book does a really good job in Chapter 1. It's tables 1-3 through tables 1-7 of giving good examples of how patient assignments would work in each of these different types of nursing care delivery systems. Again, it might be something that you've kind of been experiencing but never really thought, what is our current nursing care delivery system at the place where you work or the place where you've been doing clinicals. But next time you're in clinicals and your precepted clinicals, wherever it is that you're at, take a look around and kind of see how you think this works and try and envision what it would be like if we were utilizing one of the different kinds of what we're currently using. But really, honestly, what model a hospital chooses to use is typically dependent on money, because all things seem to be go back to that aspect in one way, shape, or form. The staffing capabilities, how many do they have of nurses, LPNs, aides, techs? What is the mix? Who makes up their nursing staff that they've got? And then also, what kind of patients do we have? There are certain patient populations that lend themselves better to one style or model of delivery than another style or model of delivery. And then overall, the overarching aspect is, what is the hospital's mission and philosophy about care? But let's talk a little bit more about each one of these. And the first we're going to talk about is total patient care. This is the oldest method of nursing care. This is the one that good old Florence Nightingale used to use. It was used predominantly in our healthcare systems up until about the 1930s. So it's been quite a while, getting closer to 100 years now, since this has really truly been the way or the model of nursing in the United States. But what this is, not sure why that happened. Let's see if I can get back to where we're at. Okay, there we go. What this is where one nurse assumes accountability for the complete care of all the patients in a certain group or assignment. So the other thing to keep in mind with that is that the coordination of that care does not extend beyond her or his given shift. So it's just for the 8 or 12 hours that they're there, but they are totally taking care of every aspect of the care of the patients in their assignment group while they are there. Nobody else is involved with it. They're doing absolutely everything. So some of the advantages to this is that there was good quality of care. All the care that's given is given by a highly skilled person because it's given by the nurse. So there's nothing that's being done by an unlicensed or unskilled, technically, personnel as in aides or techs. There's also a lot of continuity of care that's given for the shift, because if one person is totally involved in every aspect of their care, there's no need to really communicate what's going on from one person to the other, and this in turn leads to pretty high patient satisfaction. And it also reduces the need for communication, so there's no communication issues, and it reduces the need truly in a lot of ways for supervision and delegation, because if one person is doing all care, there's no reason to really need to delegate. So there are some advantages to this type of care, and patient satisfaction and quality of care are both very high in this model of care delivery. So you ask, why in the world have we not been using this since the 1930s? Well, the biggest thing is that it's not very cost effective. The number of registered nurses you need to truly be able to do total patient care is quite significantly different than the total number of registered nurses we have available to us today. Some nurses actually don't like it, so nursing satisfaction can be an issue here because they feel like they are doing jobs or performing in roles that are kind of beneath them or beneath their skill or technical abilities and levels. And it doesn't use them to the best of the ability because we're having them do things that somebody else could very easily do. So that's total patient care. You will still see it in some situations. You'll see some modified versions of it more than truly the version that this is talking about, because there are times when I would say that in my nursing career I had total patient care, but in its true sense of the definition and what it was once designed to be, that is not what I have ever experienced in my nursing career up to this point. Then functional nursing began in the 40s. It kind of took over from total patient care. It's something that, again, I've never done this. I'm not sure that I would like to do it. It's something very different to me from what I've ever known about in the past. But this is where work is allocated according to a specific skill or task. So the charge nurse is the one person on the unit who knows what's going on all patients, and then she assigns a medication nurse, an assessment nurse, a wound nurse, and so on. So in a lot of ways, if you think about it, this is kind of how we do simulation, which think about how disjointed that feels for you in the simulated environment from most of your med-surg and specialty simulations where you're assigned a role, you're the vitals nurse or the meds nurse or something. That's how we actually administered care to the patients. So some of the advantages of this is that it is fairly efficient and fairly effective as far as regularly performed tasks, because if you are the med nurse, you get very good at giving medications and you know a lot about the ins and outs, the side effects, the ups, the downs, the whatever around all of those meds. And you can actually accomplish quite a large number of tasks in a given shift when you're only focusing on one particular task. When you can literally say, the patient asks you for water or something, that's not my job, which I don't know that we would ever really say that, but you can kind of get the idea of what we're talking about here. It is fairly efficient financially. But some of the downfalls to this really outweigh any of the financial benefits that we might have, in that there's really no continuity of care. There's no one person who knows truly what's going on with all aspects of that patient, except for maybe the charge nurse. And if you think about that, the charge nurse knows this information about every patient on the unit. How detailed can she know it on any one given patient? So there is really a big issue with communication, and some things just not getting done, and just really no one seeing the big picture. We all just see one piece or one part of the picture, and there's a lot of things that can get missed within this. So you can imagine that there's decreased patient satisfaction as well as decreased nurse satisfaction and overall poor accountability for anything that's going on with the patient. The one time that I kind of see us doing a functional nursing model, and I have been a part of this aspect, is when we are in a I don't want to say necessarily dangerous situation, but kind of almost a triage situation. The times when I've been a part of this is that when there's been huge snowstorms and you're so short-staffed and you're trying to just get the basic needs of the patients met with the nursing staff and or techs, aides, LPNs, whoever else we might have available to us. And so then you kind of do go down and say, you just do all the vitals, you just do all the meds, you just do, and we assign in that aspect so that every patient is at least being touched, and hopefully we're getting enough different eyes on the patient to know if there's anything immediately urgent that needs to be addressed. So it does have its place, but it's just not a very good model for it to be purposeful and for it to be beneficial on a day-to-day basis. And then primary nursing is definitely something that I've had. When I've said that I kind of feel like I've done total patient care, in reality it's probably a lot closer to this primary nursing. With primary nursing, the nurse designs, implements, and is accountable for all of the nursing care of their clients that they're assigned. So you plan, you set the goals, you evaluate the goals over a 24-hour period of time. And when I worked at Cardinal Glennon, we did primary nursing a lot. So I would sign up to be Child X's primary nurse, and that meant that as the primary nurse, every time I worked, I took care of that child. But even when I wasn't at work, I was still coordinating the care and kind of establishing the care plan for what the other nurses who were not the primary nurse were responsible for doing. Some of the aspects that happen with this is that it kind of helped us improve the quality and continuity of care, and it gave you the ability to really truly develop a relationship with that family and that patient. In some aspects, it kind of simplified communication, because as the primary nurse, I took the brunt of responsibility to make sure that communication between all partners within the healthcare team were communicated with and were knowledgeable of what my child's needs was. And in that, one of the other advantages is that it does have an increased nurse satisfaction, because I felt very powerful to be able to make a big impact for this child and this family that I was taking care of. One of the big disadvantages of primary nursing, one of the reasons why it's kind of gone by the wayside, is that it does cause us to have an increased number of care hours per day, and it requires more nurses to truly do this effectively. The interesting thing when you look at the research on primary nursing is where you might say that one of the advantages was that patient satisfaction went up. Patient satisfaction data is fairly inconclusive for this model of nursing. We can't say definitively that it went up, but just on the same thread, I can't say definitively that it went down. It also can be fairly difficult to truly actualize and implement because we don't keep patients in the same level of care for extended periods of time now like we once did. So they're constantly transferring to lower levels of care at fairly rapid pace. So it almost makes the need for primary nursing to be null and void. Now I can see the need for this a lot differently in a long-term rehab type setting where those patients are with us for extended periods of time. But with our average patient stay being 2 days thereabouts, give or take, depending on the year, the month, the week that you look at the numbers, it doesn't really behoove itself to being a necessary aspect of the care to have primary nursing. Now, team nursing is the most common form of nursing or most common model of nursing in the United States, and this is what most of you guys are probably used to. But you use a team of nursing personnel, and the nursing personnel is typically your charge, your staff, your LPN, and your unit aides or techs, depending on what they're called in a given unit. That's your team. So it allows us to use non-nursing personnel to help assist us with nursing duties. The coordination of activities requires more than one person, which facilitates the oversight of some of the newer nurses. So that's actually one of the advantages. Because of the aspect of how team nursing is set up, it makes it easier for us to help mentor along novice or new nurses into becoming more proficient and more skilled in their job. It also allows us to have a smaller group of patients, which allows us to have higher quality of care than with functional nursing. Because with functional nursing, you're responsible for all the patients on the unit. When you're doing team nursing, you might take care of a few more patients than you would with primary nursing, but it's not to every patient on the floor kind of aspect. So with team nursing, you might have a little bit larger patient assignment, but it is still very, very manageable if you have a good team working with you. And that's a pretty big if. One of the disadvantages of this is because it's a team of people, communication is definitely a need. We need to be able to communicate effectively, efficiently, and timely. And we all know that in almost everywhere we've been, communication is probably one of the most challenging things to do well. And that's the case here too. So that is one of the disadvantages, is that if you have poor communication, team nursing doesn't work the same. There's also times where continuity of care may be diminished, kind of like with functional nursing, but not to that extreme. But just because there's times when the tech doesn't know what the nurse is doing, the nurse doesn't necessarily know what the tech is doing, and they might either both be doing the same thing, or worse, neither one doing something that's very needed in the overall care of that patient. So it can lead to some admissions in care. It can also lead to some role confusion of what is my job, what's not my job. And I know that there are sometimes a lot of emotions involved with this, and we need to try and take out that emotion as much as we possibly can and just make sure that we're getting the patient's needs met. So I would venture to guess that when you look around your nursing units, you're probably going to see that team nursing is the model that you follow, or that your facility is following where you're precepting. But kind of envision, what would it be like if we did total patient care or functional nursing, or primary nursing, which might be the more realistic of them. Those of you who might be in a higher acuity setting like an ICU or something along those lines could probably envision how primary nursing would look best there. But take some time to kind of look at it, and then take some time to look at those tables in your book in Chapter 1 to see how nursing assignments change depending on the model of care delivery facility. Now, case management is something that's fairly new, and it's kind of come about with the advent of all these care pathways and order sets that's been driven out of that managed care phenomenon that we've been experiencing over the past 20, 40 years. So with case management, there's an individual whose job it is to actually organize the care of the client and what they need. And typically case managers are set up based on population of diseases. Like there'll be a case manager for the cardiac diseases, or we always have one case manager who is assigned to maternity. And if there's a NICU in that facility, typically the maternity case manager is also the NICU case manager. But their whole purpose is to help us get the most for the patient that we can to meet their hospital-based needs or their medical needs at the lowest dollar in the most efficient way we can. So sometimes you might feel like the case manager is your worst enemy, but in reality a lot of times they're your best friends, because they know all of the resources that are available in the community to help these patients be able to transition out of the hospital world faster. And so they've got a wealth of information, but they are the ones who typically are calling the insurance companies to get verification for yet another day hospital stay or something along those lines. So it is important that we're communicating with the case management team honestly and efficiently. They need to know at a moment-to-moment basis, and every hospital has it set up a little bit differently about how they're going to go about getting those communication processes met. But it's something that takes some time to kind of look around and see what you can figure out about how case management works at your facility. Because again, it's a little bit different depending on where you're working and what you're going to see. So kind of look into it to see if you can figure out how case managers are being used. Some of the disadvantages to this, to utilizing case managers, is that it can lead to fragmented communication because everybody thinks that the case manager might be the one to pull it all together when in reality they may not be. They may not even be aware that that is an issue or that it's something that needs to be there. The other potential is that we can, again, just like with managed care, we can potentially lose sight of the patient in front of us and lead to some fragmented care and some patient needs that aren't going to be met because we're going to be going based on whether we got verification for another day or not. Okay, so when we look at leadership, and really honestly, that's what this class is about. It's about healthcare leadership, nursing leadership, and how are we going to handle that? What's our role going to be? Because it is the expectation that with you guys all having your bachelor's degree, you will have a leadership role, whether formal or informal, at whatever facility you work in. So when you look at trying to establish some of the leadership priorities, what are we going to look at? How are we going to make it work? What is our priority? So think about the places you've worked or the places you've done clinicals, and what do you think the nurse leaders in those areas, what should their priorities be? What does our healthcare environment need? How are we going to make it happen? And this is kind of an ongoing question to kind of keep in the back of your mind about when you're looking around your unit. Try and step aside a little bit from the focus of just tasks and skills and what you need to do next for your patient, but try and look at the bigger picture. One of the biggest things that we need to be able to do in our nursing units is create a common vision. If everybody who's working on the unit understands what the purpose is of the unit, has the same goals, has the same objectives, has some sense of ownership in helping meeting those goals and objectives, that nursing unit is going to run much better. But that is much easier said than done. You cannot do this just with lip service alone. There needs to be follow-through and follow-up behaviors and actions that the nursing staff need to see from their leaders to truly make this work. But if the staff that's working the unit feels some sense of ownership, some sense of connectedness to the overall mission and vision and philosophy of not just the unit but of the entire organization, they're going to be a lot more willing to work harder and work smarter and help that facility meet its goals. But it is, again, like I said, much more challenging to actually do than it is to say. So again, kind of think back when you're on your floors about what are the needs of this unit and how would you, if you were given carte blanche to be able to do it, how would you do it? What does that look like? What does that kind of leader look like? What are the skills and traits that that person needs to have to truly be able to get the leader to move in that capacity? It's not always easy, so keep that in mind. And some of the biggest challenges we have today in nursing is the generational conflicts or generational challenges amongst our nursing staff, the work environment in and of itself. We know that negativity breeds further negativity, but how do you get rid of it? So we'll talk a little bit more about that. And then one of the other ones, and this is one that you guys are going to be tested on frequently in NCLEX, is just the appropriate level of supervision and delegation. How are you going to make that work? So think about the generational challenges. We know that we have two big classes of patients that are working at the hospitals not patients, two big classes of nurses that are working at the hospitals right now. This is not about the patients, this is about the nursing staff. So you've got your baby boomers, and then you've got your Gen Xers. And I have to say I'm very hesitant to classify because I used to be very resistant to always being classified as the Gen Xers or Gen Ys and stuff like that because I didn't want to be lumped into a group of people. But your baby boomers are the ones who were born at the end of the World War II. They're often called the sandwich generation because they're often caring for their family, both their children and their elderly parents, and having to figure out how to meet the needs of both groups. In general, baby boomers tend to value group participation and getting to consensus. They think that recognition is highly valued and they care tremendously what other people think about them. And they also have a very strong sense of family obligations, and that's going to require time to meet those family obligations. But on the flip side, they have a very strong sense of loyalty to the facility at which they're working. where Gen Xers are kind of considered, or millennials, or we can kind of go, these kind of merge, and we can get into specifics with each one of them. But in general, these are individuals who have a very distinct set of values and expectations about work. They desire to work with leaders who are effective and intelligent, who are approachable and supportive, receptive, and do a lot of mentoring. So it is very important to this generation of nurse to work for somebody that they value and respect as their leader. And if they do not have that value and respect for the leader, their commitment to that organization will be drastically different than the equivalent in a baby boomer, where they want to have respect for the organization, but they can get by with a bad leader a little bit easier sometimes than a Gen Xer might be able to. A Gen Xer needs to have frequent feedback and frequent, the right word to say it, not necessarily does their egos need to be stroked all the time, but they do need to have and require feedback. And one of the best ways I could describe this, and it kind of was a light bulb moment for me when I had a chief nurse executive discuss it with me in this manner, but she said in a lot of ways this is a Pepsi generation. She was talking about my generation of kids at that point in time. But we're used to pushing a button and getting what we want. So it's really an instant gratification. And if you don't get that instant kind of feedback, you don't really know what you're doing. And there does tend to be a school of thought that if I didn't get any feedback on it, either it's not valuable or it doesn't really matter how I did. And that's not necessarily the message that the leaders are trying to send to you. It might just be a timing aspect of what's going on. But they really, Gen Xers want to be valued and trusted for the contribution that they're giving, and they want that feedback of what's happening at what given time. Then obviously creating a work environment is one of the biggest challenges that nurse leaders have, because we need to create a work environment where nurses are accountable for the behaviors and the actions that they're doing. But we also, really honestly, our big goal and focus should always be about empowerment. We want to empower the people who are working on our units to be able to have an input and control and effect into the bottom line, whether it's patient satisfaction, patient outcomes, all of the above kind of aspect. So we're really trying to set up a place where it is safe to be creative and to have ideas that are outside of the box and to come up with solutions. On the flip side, it needs to be an environment that is safe to make near misses and mistakes without fear of retribution or your job. Because when you work in an environment of fear, there is very little creativity and problem solving that's ever going to be able to happen at that point in time. And we also need to just make sure that our supervisors that we have the right people in supervisory positions and that they know what their role is. Supervisors need to make sure ultimately that we have a competent and disciplined staff that's meeting the objectives of the facility and of the floor. It's sometimes challenging to think in a supervisory role that may be a lower level supervisory role that we really have that responsibility, but we do. We're the ones who are there at the bedside day in and day out with the nurses. And so sometimes that level of supervisory role is one of the most important ones, and one of the ones we really need to be striving hard to make sure we've got the right people in that role. And some skills that they need to have is that they need to be able to be good communicators as well as good listeners with good, quick, appropriate follow-up and follow-through. Those are probably the things that are going to make the biggest difference in the success or failure of a unit, is if your supervisors at that level have necessary. This is a table I found that I decided to put in here that just really highlights some of the aspects of Gen Xers. And I don't have the equivalent for baby boomers because it's not as significantly drastic. And if you think about it, in a lot of aspects, our hospitals are run by baby boomers. And so the perceptions of the hospital is the perceptions of the baby boomers. So that's in a lot of ways where our dichotomy is coming from, is that the big dogs, the most powerful people in the facility, are typically that baby boom generation. So when you've got a whole lot of folks who are in these Gen Xers and some of these other generations, it does cause a little bit of discordance between the two. And you can see a couple examples here. I've got this slide and the next slide where, and I mean, I have to laugh because some of these are so true of me, like the 10 to sidestep rules with no connection to the mission. If I don't understand why you're asking me to do it, I'm not necessarily inclined to do it. That's not necessarily a good trait to have as an employee, because although I may not see the reason for the rule, hopefully the rule was not made needlessly. Okay, so you can see that the perception of the hospital is that the rules are all mission driven, and whether I understand it or not, I should follow through with them just because it's a rule. So these differences, and this slide continues on with some of the differences that that cause the rub or the friction between the Gen Xers and their potentially baby boomer bosses or perceptions of the hospital. So I'll let you guys read through these on your own, because I know that you're very able to do so. Then the next thing I want to talk about is empowerment, and I kind of alluded to this in the previous slide, that truly empowerment is the thing we are searching for. If we have empowered employees, we will have a unit that is phenomenal, because if the employee feels like they are enabled to recognize and use their strengths and their abilities to impact change for that unit, it is going to be a very good thing. And when you have empowered employees, they tend to be more engaged in the decisions that are going to affect the work life and client care. What better thing can we hope for? So this is really honestly what we are striving to achieve. And there is a lot of different theories out there about how to have empowered employees. But I have to tell you, you could look at almost every theory out there. You can enact that theory very well and have very good success with it. You could take that exact same theory, have a really poor leader in the role of the person who's supposed to be enacting it, and have vastly different outcomes. This is actually kind of from an education perspective, or crossing over into the educational world. One of the things I'm really interested in studying and doing my dissertation on is that how do you bottle, package, teach, whatever, the person to be a leader who has the ability to empower either their students, in my case from the education aspect, or their employees if we're going from the hospital-based aspect. And it's not it's not a one-trait skill. It's not something you can just listen to a video on and suddenly have it. It takes a lot of time, a lot of reflection to get it, but it is the thing that we are looking for, because when we have empowered employees, we are going to have better outcomes on our nursing units. That's really honestly the bottom line. Alright, let's kind of look into safety, because when we're talking that client culture of care that we're trying to develop here, we need to look at safety. And there is a wonderful, I'm not sure if wonderful is the right word, but there is an article from the Institute of Medicine that's titled "To Err is Human," and we're going to talk about this a little bit when we get to class. But this article really highlights the aspect that in healthcare we are all human beings. And because of the nature that we are all human beings, from the highest ranking person in the hospital to the lowest ranking hospitals, we're going to make mistakes. Do we have the safety mechanisms in place to protect the patients from the mistakes we're going to make? There was a stat from 1999, so it's a very old statistic. I haven't seen a more recent one, that 98,000 Americans were killed by medical errors alone. That is a significant number. We can tell you that even still to this day, more deaths occur each year from medication errors than do from HIV, AIDS, breast cancer, or highway accidents or traffic accidents. Phenomenal, the mistakes that are being made at the bedside and the impact it's having on patient lives. Now, I will tell you that is not a clean statistic. You can't say it's an absolute cause and effect kind of situation, and that if the mistake was not made, that the patient would not have died. But there is some theory going along, and when we actually claim the statistic, it is with pretty good thought process that all things being equal, if X had not happened, then the patient would not have died. We know at this point that most commonly errors are caused by a couple of things. There's faulty systems or processes in place that don't protect our patients and don't protect our employees. So it's a system problem. The other aspect is that there were conditions that led people to make mistakes and or fail to prevent them. So again, it's a splitting of hair of there being a system error, but essentially for an error or mistake to happen, the thought is a Swiss cheese analogy, where all the holes in the cheese have to line up just right for that mistake to have made it all the way to the patient. Or at least that's what we hope is happening. And obviously, if we have this many patients dying of medical errors or human errors, then our holes in our Swiss cheese are too frequently from what we want to. This is just a couple of simple rules, I call them, but simple is almost an oxymoronic term because they sound so simple and sometimes they are very challenging to actually enact. But these are rules that if healthcare systems can follow them, our error rate would significantly decrease. But we want to make sure that all initiatives we do in the hospital for client safety, this includes having something called near-miss reporting. Near-miss reporting is something fairly new in the big scheme of things, but it means that we report mistakes that almost happen, not just mistakes that did happen. But we want to look at the stuff that almost happened for a couple of reasons. We want to look at why didn't it happen, because if whatever that safety gotch was, or stopgap was that prevented it. We want to make sure we're able to replicate that. But then we also want to look at how did we get to almost? What was going on within our systems that did not stop it sooner? How did we get so close to that patient and having a mistake? So near misreporting of just anything from medication errors to transfusion reactions to communication issues to anything, near misreporting. Technology, we know we're using a lot of this. Almost all of our facilities, if not all of them in the St. Louis area now, have some version of electronic medical record, and we know that that is supposed to help us prevent patient mistakes. I think it's going to be one of those learning curve things where we're going to have a few mistakes because of it before we truly actualize the benefits of having it. But we know we're there. Evidence-based nursing practice is the obvious. We need to be doing what research tells us to do, not what we've always done, and we want to make sure that we've got good rationales behind the behaviors that we're doing. We want to have mandatory reporting. Hospitals voluntarily report serious client harm right now so that we can analyze mistakes. We want that to be a little bit more strict or stringent and have it go into a national database so we can look at these things not just in isolation at that one facility, but look at them across the board. We want to make sure that we've got quality and safety initiatives in the community and in pharmacy practice, not just in the hospitals. We want to increase health literacy. If we can increase health literacy, our patients understand more of what we are saying to them so that they can be more active participants in their care. That is extremely important. This pay for performance thing is something that's very hot right now. This kind of goes hand in hand with what we were talking about in the previous podcast with report cards, but it is pay for performance, just what it sounds like. You're compensated according to the measures of your ability to meet your goals and the quality of care you're able to provide. If you can't do good care, you don't get paid good kind of aspects. And we know money talks, and we know that healthcare finances is something that's desperately in need. So there is a thought that that might help us. I'm not sure I entirely believe it. I think it could have somewhat of a positive impact, but I don't think it's the end-all be-all. And then really the liability protection for disclosing errors. This goes hand in hand with mandatory reporting and initiatives in client safety, but the whole thought is that if I report a near miss or an issue that happened, that my facility is safe from not losing its reimbursement. And until we get there, it doesn't matter what else we do. Because if hospitals are afraid of losing money and nurses are afraid of losing their job, which would be their money, we are never going to truly get to a safe hospital system because money talks and we all need it. So those are some of the quote-unquote simple systems. And then IOM, which is the organization, Institute of Medicine, that wrote that 2 Errors Human article that we're going to look at. Here are some of their recommendations, is that we need to be making sure that we are basing our care on that clients receive care whenever they have a need for it in whatever form, not just face-to-face visits, so that we're altering how we're administering the care, that it's based on continuous healing relationships, but the relationships are not just one-dimensional, meaning that they don't just exist in one avenue or one venue, that we are able to be creative in how we administer the care, that it might be simply setting up Skype-type aspects where the patient's on the phone at home getting assessed by the physician or the nurse practitioner or something along those lines. We also want to make sure that we're customizing our care based on client needs. This is coming out of that whole thing with managed care and with us having lost sight of the patient. We need to have managed care, we need to have controls in place, but we need to never lose sight of the patient who's right then and there in front of us. We need to know that clients should be used as a source of control, that the system's designed to meet the most common types of needs, and but that the clients are given the necessary information that they need to be active participants in their care. So that's what we mean by clients as a source of control. They need to have a lot more input into what's going on to them. We need to make sure that we've got a system built where there's shared knowledge and it's a free flow of information, that there is no communication gaps that's happening between the different levels of care, the different healthcare practitioners within the healthcare team, and this is kind of where the hope is with electronic medical records, that everybody will have access to the most up-to-date current information. We need to make sure that we are keeping safety as one of our primary focuses. We know that. You know that you're going to be tested on that tremendously on NCLEX. It's all about safety, 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 safety. We need to be very, very transparent. What do I mean by that? Is that everyone understands what everyone else is doing. That the information is readily available to whoever is in the healthcare team as well as to the clients themselves. We should not have any secrets or hidden agendas. It is easier said than done to be transparent because oftentimes we have things, cultural aspects, family desires, physician desires, nursing desires that sometimes cloud that transparency that we need to have. We also want to create a system where we're able to anticipate client needs rather than react. We want to be anticipatory, not reactionary. We want to make sure that we're utilizing our services and our supplies reasonably and well to where we're limiting waste, we're being good stewards of the resources we've got, and ultimately we want to have a system where there is cooperation amongst all providers within the healthcare system. We are very proprietorial in healthcare today. We don't necessarily like to share our information very well, and that's one of the things that has got to stop if we're truly going to get to a point where the care that we administer to our patients is safe, efficient, effective, and meets the best needs for them. All right, I'll get off that soapbox for a little while, but we'll talk more about this when we get